I'm Dr. Robert Hegley, and on behalf of CME Outfitters, I would like to welcome you to today's educational activity entitled Overcoming Obstacles, Expert Perspectives on the Diagnosis and Management of Familial Chylomicronemia Syndrome. Today's program is supported by an educational grant from Ionis Pharmaceutical Company. Today's program is being brought to you by CME Outfitters, which is an award-winning, accredited provider of continuing education for clinicians worldwide. Some housekeeping. Follow us on X. More information there. So I'd like to introduce our faculty for this evening. So if you discount me, we have an extremely esteemed faculty. I'll start with myself, though. So I'm Rob Hegley. I'm an endocrinologist, professor of medicine in London, Canada. And also joining me this evening, I'm absolutely thrilled, two superstars in lipids, Alan Chait, professor in the University of Washington, esteemed endocrinologist, lipid specialist in Seattle, and from San Diego, my colleague, Dr. Joseph Whitstam, professor of medicine, endocrinology, division of endocrinology and metabolism at the University of California in San Diego. And we are absolutely thrilled to have with us tonight to give the patient perspective, Mr. Jeff Wertalik, a patient advocate of the FCS Foundation from Mission Viejo, California. So we have learning objectives for this evening, and I will go over these in order. So the first objective is to identify key diagnostic elements of FCS. The second objective is to integrate multidisciplinary approaches that may facilitate adherence to FCS dietary guidelines. And then third, to assess recent study data evaluating current and emerging FCS pharmacologic therapies. Hypertriglyceridemia is a very, very common clinical problem, like probably the most common referral in my lipid clinic. And it's associated with numerous secondary factors, including age, elevated blood glucose, higher body mass index, obesity, waist circumference, also with total cholesterol, and very commonly this yin-yang relationship that I'm sure you're all familiar with reduced HDL cholesterol. So of the American population, 18% of people have triglycerides greater than 200 milligrams per deciliter and 0.4% greater than 1,000. So that 0.4% is actually, extremely common. It seems like a small number, but in absolute terms, it's actually quite a large number. And the associated medical conditions include obesity, metabolic syndrome, diabetes, chronic liver or kidney disease, and then a wide range of hormones and drugs. Okay, so just a question to begin. And this is multiple choice, and you'll have the opportunity to enter your responses. I'm going to read it because we're already getting responses. You guys are like so smart. So I'm okay, but I will quickly read, but please feel free to enter your responses. When do you suspect familial chylomicronemia syndrome in your patient? When extreme triglyceride levels cannot be explained by other causes? When a patient has got high LDL and normal HDL? When an overweight patient has got high triglycerides and atherosclerosis? When an older patient experiences pancreatitis? Or the common option or friendly option is I don't know. So please go ahead and respond, and we'll tally your responses. so we have then our summary here. And so just to show you that the correct answer is indicated with the box when extreme triglyceride levels cannot be explained by other causes. And we have about half of our participants have chosen that answer. And then about a quarter were not sure. And then the minority had the answers that were incorrect. So the point here is that familial chylomicronemia syndrome is a subset of these extreme or severe hypertriglyceridemia. Typically, in adult patients that we see, there are secondary causes or other causes that are associated. But if in the absence of other causes, this should then trigger you to think, well, maybe this could be FCS. Okay, let's start with our case for this evening. We'll come back. I mean, there are like some of the elements in those questions will be covered. So Richard, he's a 19-year-old male, presents to the emergency room. Oh, I'm sorry. At this point, I have jumped the gun here. This is a case that is provided by Dr. Chait, and I would actually love Dr. Chait to take over at this point.
All right, Rob, thank you. As you've just heard, this is a 19-year-old man who presents to the emergency room with a considerable abdominal discomfort. His history is that he's had intermittent abdominal pain for many years, most commonly after he goes to parties. He's now at college, and his episodes of abdominal pain have actually increased since going to college. His family history is negative for both pancreatitis and cardiovascular disease. But the evening prior to his current visit to the ER, he attended the opening of baseball season, and he had some hot dogs, some beer, and that seems to have precipitated the abdominal pain. So on physical examination, he's 5'7". He's only weighs 120 pounds with a BMI of 18.8. He's got a slight fever. His pulse is 132, blood pressure, as you can see. And he's in considerable discomfort with general abdominal tenderness, but particularly marked tenderness in the upper quadrants. His labs, he's got a plasma triglyceride of 6,378 milligrams per deciliter. His cholesterol is relatively low when compared with his triglycerides. His sodium is low at 125, potassium 4, blood glucose normal at 91, and has a high serum amylase, confirming a diagnosis of pancreatitis. So here we have a young male who's underweight, he's not diabetic, and he has confirmed pancreatitis and a high triglyceride. So this is triglyceride-induced pancreatitis. And when you see extreme triglyceride levels like this, there's almost always a genetic component. And on the right upper corner, you will see what his plasma looked like. You can see on the left the creamy, almost tomato soup appearance of his plasma when drawn and just sitting around for a few minutes before it's even centrifuged. This is compared with what a normal plasma would look like on the right. So Richard has triglyceride-induced pancreatitis. The next slide is actually probably one of the most important slides around, because I'm going to go through this slowly, because this is going to really help us differentiate two of the causes of severe pancreatitis, by which I mean triglycerides above 1,000. Now, the situation here is in the middle panel, we have familial chylomicronemia syndrome, the topic that we're talking about today. And on the right, we have what we call polygenic multifactorial chylomicronemia syndrome. And it's really important to differentiate these two. The reason for which is that if you have proper FCS, it is a major burden on the patient's life, as you'll hear from Mr. Wertalik in just a few moments. And also the treatment is completely different from the much more common multifactorial chylomicronemia syndrome. So let's start off with the old names. If you still use the Fredrickson classification, which I don't think you should, it was type 1 for familial chylomicronemia syndrome and type 5 for the MCS. The major differences in the lipoproteins is that in FCS, it's really chylomicrons that accumulate, whereas in MCS, chylomicrons, very low density lipoproteins, and low density lipoproteins and remnants of the triglyceride rich lipoproteins can accumulate. The other lipoprotein abnormalities in FCS, VLDL, LDL, and HDL cholesterol are all reduced. So it's really chylomicrons that are accumulating. So LDL levels would be low and ApoB levels would be low. Whereas in MCS, chylomicrons, VLDL, and their remnants accumulate, so you're going to get much higher cholesterols in association with a very severe hypertriglyceridemia. In terms of the onset, it oftentimes is in the pediatric group that we first see FCS. Here you oftentimes will find an infant who fails to thrive and has found to have milky plasma. This is classical FCS, but as you'll hear, many patients will present in adulthood, as our patient advocate today will tell us. It's always in adulthood that you see the presentation of MCS. The prevalence, and this is truly important, the prevalence is about 1 in a million for MCS. For FCS, it's extremely rare, where it's about 1 to 405 to 500,000 for multifactorial chylomicronemia syndrome. In other words, it's even though rare, it's much more common than FCS. And this is really important because what the goal of this program today is to help you identify those rare cases of FCS that require preferential and special treatment. The genetics you're going to hear a lot more about from Dr. Hegley in just a moment, and I'm not going to say much more about it at this point in time. One other thing that's important to notice is a history of cardiovascular disease in the family. It's almost always absent in FCS and often present in MCS. Secondary factors are minimal or absent in FCS and are quite common in MCS, including factors such as those associated with the metabolic syndrome. The genetic causes Dr. Hegley will talk about, and the treatment, again, is quite different. And this will be discussed by Dr. Whitston as we progress with the program. So let's talk one other thing about differentiating the two. What I'm showing here is FCS in blue, MCS in red, and what you will see is that the individual patient with FCS has more pancreatitis and more episodes of multiple episodes of pancreatitis. Now you can see it's much higher in the blue bars than in the red bars, but remember, this is for an individual patient per patient. When you think about the prevalence of the diseases, MCS is so much more common that actually when you see a patient in the emergency room presenting with triglyceride-induced pancreatitis, it's much more likely to be due to MCS. Cardiovascular disease hardly occurs in FCS, and it does occur quite commonly in MCS. And as I've already alluded to, metabolic syndrome features are rare in FCS and much more common in MCS. But again, remember the difference in prevalence between the two disorders. And again, you will see much more common metabolic features in the multifactorial chylomicronemia syndrome. So at this point, I think it's time. I want to just give you one more slide, which I think will help in the clinical differentiation between these two disorders. So let's start off on the left side of this panel when you've got a patient who's got triglycerides above 1,000. This can be diagnosed at the time of just a routine blood examination or blood taken for any other disorders, such as a patient who's got diabetes, or as in the case that we're talking about today, when the patient comes to the emergency room with abdominal pain or pancreatitis. So what has been devised by a number of groups throughout the world are screening tools. And on the right, in the middle here, we see one such screening tool. This was devised in Europe, and it's a very interesting one. Basically, it gives 8 factors, listed 1 to 8, and gives a particular score for each individual factor. So, for example, if you've got a fasting triglyceride greater than 10 millimoles on 3 consecutive blood draws, that gives you a score of 5. There's a negative score. One of these is a negative score if you had a previous triglyceride of less than 2 millimoles, that's a negative score. And in terms of converting millimoles per liter to milligrams per deciliter, to make it simple, just divide by 100, or just multiply by 100. It's actually 88.6, but for practical purposes, 100 will get you the right answer. So let's add up the scores. When you have an individual patient, you've added up the scores. If you've got greater than 10, FCS is likely, very likely. If you've got less than 5, FCS is unlikely, very unlikely, and then in between. And then some other additional characteristics have been added to these screening tools. And for example, a low BMI, that would be another reason for having, for thinking more of FCS, and a low LDL cholesterol below 40 milligrams per deciliter. This too would give you the feeling of a low FCS. And then, if possible, once you've made a clinical diagnosis of FCS, then if you have the ability to do so, a genetic diagnosis is really the gold standard for confirming the diagnosis. So before we go on, I'd like to bring Mr. Wertelich into the story. And Jeff, I'd like to maybe ask you a few questions related to what I've just said. So how old were you when you were diagnosed with FCS?
My diagnosis honestly didn't come until about 5 years ago. I
And
was
by
42.
looking at your gray beard, you're not 20 years old anymore, or
No,
50.
it,
So,
it took many, many years to find someone who understood what I was going through.
so you'd been complaining to doctors for a long time, but they hadn't come up with the correct diagnosis. Is that the case?
Correct. I've had my gallbladder removed unnecessarily. Alcoholism was constantly thrown at myself and my wife, which was not an issue.
Okay. And so how many misdiagnoses would you say you had before the correct diagnosis was made?
At least 5 before I finally found a lipid specialist.
Okay, fine. And how did they make the correct diagnosis? Was it on clinical grounds, or were you genetically tested?
It was clinical grounds. He understood what I had been going through. I had even had the skin condition that is very common with FCS patients, which dermatologists just called an acute dermatitis.
And I
Just
presume
hearing
you're
my
referring,
story, he was able to.
you're referring to eruptive xanthoma, I presume. Is that correct?
Yes.
And the usual site of that is on the buttocks. Is that where you had yours?
I was fairly covered.
Covered in them. Oftentimes it's confined to the buttocks. And, in the clinic, we often don't examine patients' buttocks and we'll miss them. So a point of guidance for clinicians listening to this: when you have a patient with a high triglycerides, examine their buttocks. Okay, and Jeff, I alluded to the fact that people with FCS tend to have a lower BMI. Where do you fit in that scheme? Are you
I'm a little more in the upper BMI, just genetically.
All right, so you're a slightly unusual character for FCS.
Correct.
Do you have
6'5" and about 270 pounds.
Oh, wow. Okay. Do you have any secondary features, any other disorders, diabetes, any other conditions?
I'm battling with diabetes a little bit. Other than that, no.
Now, diabetes in people with FCS oftentimes is a result of multiple episodes of pancreatitis leading to pancreatic damage. Have you had pancreatitis, and if so, how often?
Yes, for until I was diagnosed, I had pancreatitis about 7 times, I believe.
Okay, so it's quite possible
Over,
that your diabetes might be related to pancreatic damage.
it's very
Okay.
possible.
Anything else you'd like to tell us, Jeff, before we move on?
It's just challenging to find a doctor who understands what you're going through. I live in New Jersey, and obviously being close to New York City, there are specialists all over. And still, it took me until I was 42 years old to get a proper diagnosis. Um, I hear many things in different FCS groups that I'm in where people just don't know where to turn. They're asking other patients for help, which is not the best clinical assistance you can get. So it's very, very challenging in many parts of the country and other countries as well.
Well, I guess that's the purpose of this CME program, is to try and make people understand really what the disorder is, how to diagnose it, and as we'll hear towards the end, how to treat it. So at this point, I think it would be important to talk about the genetic diagnosis. And Dr. Hegley, who's really one of the world's experts on diagnosis of FCS and other genetic disorders of lipoprotein metabolism. Rob, over to you.
Great. Well, thank you very much, Alan, and thank you, Jeff. That was very, very informative. You know, to hear the details of your own story. So we actually see that there are patients like yourself for sure in the cohorts of familial chylomicronemia syndrome who make it quite far into adulthood, and then when we do the genetic testing, they've got two alleles. So the first thing is that on the genetic basis, familial chylomicronemia syndrome, it is a biallelic condition. So this is now the current term of art for, we used to say homozygous. Maybe that's something you might be more familiar with from your like medical school genetics, or autosomal recessive. So but the point is biallelic. So that's now what at least the genetics community is using. So it means two alleles. So like being a heterozygote, having one copy. Now sometimes that's enough to then drive your triglycerides over 1,000, but we find that the heterozygotes are more represented in the multifactorial chylomicronemia syndrome, and also heterozygotes are more common in society in general. But the heterozygosity impairs you, and then there's a secondary factor on top, and then the triglycerides go really high. So in true, you know, pure wool FCS, it's a biallelic disorder where in fact it's one of these 5 genes. So it's lipoprotein lipase, which is the main endothelial bound lipase that is responsible for hydrolyzing the triglyceride-rich lipoproteins, so both chylomicrons and VLDL. But you know, the blockade is so severe that in fact that first step, the chylomicrons from the diet, you know, cannot be broken down, and so there's very little substrate later on for the liver to make VLDL. So the blockade, when you have complete lipoprotein lipase deficiency, this is like, you may then remember that term like Fredrickson type 1 or LPL deficiency. So that causes the accumulation of chylomicrons, and then everything else downstream, which requires, you know, processing and remodeling and then reuptake by the liver and then putting back out by the liver and as VLDL. So that's all compromised because this initial blockade is so severe, because both alleles are non-functional. So we used to think that that was the only case, and then maybe you might remember from, like, if you read Up to Date or whatever, oh yeah, ApoC2, I remember that. That's in Harrison's. So that's another way. ApoC2 is a cofactor for lipoprotein lipase. But what we've learned in recent years is that there are these 3 other genes that are sort of interacting with lipoprotein lipase, either at its point of synthesis and secretion. So, for example, that lipase maturation factor, LMF1, or ApoA5. That's an apolipoprotein that circulates with triglyceride-rich lipoproteins, and that activates lipoprotein lipase. And then there's this really important protein discovered by Steve Young, GPI-HBP1. That's a real vegetable soup. I won't even it's going to take me the rest of our time just to spell out the full name. So, but that's another way. In fact, that's the second most common cause. So, when we look at patients and when we break them down, these biallelic patients where in fact they are completely lacking in lipoprotein lipase or one of these four cofactors, 60 to 80% are LPL. But then the other sort of 20 to 30% are then one of these other four minor types. And then of that, it's most common, like number 2 is GPI-HBP1, and then ApoA5, and then LMF1 is actually the least common. So here, this slide was put together when there were just a few reported families in the literature, but now with genetic testing and diagnosis, these are coming up. These are actually much more common than just a few families. Still a rare disorder, but now instead of just a few families in the archives of the literature, we have hundreds of cases of each that have been documented and deposited in genetics databases. But by far the big one is LPL. And these are now found on these targeted sequencing panels that you can order from commercial genotyping companies that will test these, and then we'll come up with and then if you have both 2 alleles, or sometimes you can even have one allele in one gene and another allele in another gene, we call those double heterozygotes. So that can also cause the phenotype. However, more commonly what you would see if you order this test is you would get like a heterozygote coming back, and you think, huh. So the heterozygote either means it's multifactorial chylomicronemia syndrome, or it's just incomplete. We haven't found the second mutation, or the genotyping company hasn't found the second mutation. But anyway, these are the 5 that you need to know and that you would need to look for if you have ordered a genetic test, and you would be looking for both 2 alleles as opposed to just one allele. Okay, so I should also say genetic testing is becoming more accessible. The cost is coming down. I mean, there's still an issue of cost and accessibility. On the other hand, it's a one-time test, and you don't have to keep repeating the genetic testing. And the cost for a panel, could be now somewhere between say $500 or $1,000. So it's expensive, but on the other hand, it's a one-time test. Anyway, our patient here that Dr. Chait had been discussing didn't get genetic testing. He just received the clinical diagnosis using that scoring system, and then received dietary counseling. And so this was fat restriction. So you all know about this. This is like typical what you would find in Up to Date or like most recent treatment guidelines for how to manage this. So restrict high glycemic, high fructose foods, eliminate alcohol, obviously, and then review medications. FCS, and this is really interesting, that it's commonly misdiagnosed. It's a diagnostic odyssey, 5 visits to the clinic before the correct diagnosis is made, sometimes up to 30 visits to the clinic before somebody twigs onto the idea that this could be a chylomicronemia disorder. So Michael Davidson reported patient experiences in pursuing a low-fat diet, and you can read these here. I mean, these are described, but I think what I'd like to do at this point is bring back Jeff, and maybe and to me, it's a universal thing, talking to everybody, whether they know each other, whether they've met with FCS, but everybody has their perspective, their story about the diet, and then like what the ideal diet is and how difficult that is to adhere to. So maybe, Jeff, would you mind giving us your lived experience with the issues with diet?
Sure. The most challenging thing is that it sucks. Let's put it right out there. You can only have so much grilled chicken and brown rice and spinach in so many different ways. It is very challenging, especially for young children, to go out, similar to nut allergies. But nut allergies, you know to stay away from nuts and other things. With FCS, there's are so many foods that you can't even touch because of just fat content. A simple bag of popcorn from a company that is very healthy and says it's a low calorie alternative still has 6 grams of fat per serving, which is at least half of what they're supposed to have in one day. Right. Going out to dinner can be even more challenging, or breakfast. You don't know what they're cooking with in the kitchen. You can ask for low fat foods, but there's probably some oil going on the pan. There's butter everywhere. You really have to pay attention and know your limits. I have young children, so we end up making 2 dinners almost every night during the week because they don't want quinoa with sriracha sauce or lots of vegetables.
Yeah, very. So then, yeah, my patients tell me, many. It's just it's an interesting echo, and it's just because of it. So and does it ever happen that you think you're doing great, you are actually being diligent and religious with the diet, and yet you still you still find out your like triglycerides are 1,000 or whatever?
Oh, without a doubt.
Yeah.
One time I went for some blood work, and I was walking all tall and came in, and 2 days later, 1,300. Yeah. It crushed me. It is almost soul crushing because you work hard, you're not enjoying your meals as much, and you think you've done it, and reality sets in.
Yeah, it's a very, very. I mean, your story. So first of all, very clear, and but it's so common to patients with this condition. The other thing is that because of the fat restriction, there is this point about the risk of fat soluble vitamin deficiency. So that's something that always has to be borne in mind. The other thing is that then this ends up having a psychological effect as well, and you're sort of starting to allude to that, Jeff. But there is this, in addition to just experiencing the symptoms, despite the fact that you're adhering to the diet, it's just your diet becomes the focus of your life. I mean, it's like 3 times a day or more. And then this survey from Mike Davidson showed an impact on employment and emotional well-being. You can sense that well-being and social relationships. So
financial stresses. So many healthy foods, MCT oil, which is a somewhat viable alternative for some people. It's very expensive.
Right. Right. So just further along that line. So is that something at least that kind of breaks the monotony for you if you have MCT oil, or is that like what have you found with the medium chain triglyceride oil?
It seems to help a little bit. It's not something you have all the time. Even in the winter, I'm outside on the grill, not trying to cook in a pan or just trying to stay very focused. For me, at least, I have to be extremely diligent in my eating to have high triglycerides.
Yes.
And that's really one of the biggest challenges is you struggle to be high.
Right.
Not even good.
Yeah. So, we can, the triglycerides can still run relatively high for an average person, like even like 500. You're out of the risk of pancreatitis. But yeah, it's still, and it's a focus. Your life revolves around it. I think that's right. So we want to get to treatment really soon, but I did, I think that your perspective is so valuable. So here, the ideal approach, it would be a multidisciplinary team where, in fact, we have like a dietitian who's familiar with the low-fat diet, and then the lipidologist who can like weigh in with possible pharmacologic treatments. The family doc or the primary care provider who's there on the front line, psychologist or counselor. Sometimes that in fact these issues with depression, eating disorders are, as you can imagine, I mean, would be common, and then other specialists.
Yes, the psychological component has become more prevalent from what I can see online and just talking to people.
Yeah, for sure. So So living with FCS, there's not a one size food plan. But by the way, when so do you count grams of fat? So you're doing the sort of like, I'm guessing maybe you're sort of 15 or 20 grams or less than that a
I'm
day.
fortunate I can sit around 20 without having uh, crazy
Yeah,
issues. So I
right.
have a little bit more flexibility, but it's still not all that much.
No, it's not. When you consider the average American diet, it would be like 80 grams or more, 100 grams,
Right.
and it's like, yeah. So yeah, so it is a big sacrifice, and it does, it does really change the focus of your life. So we want to establish, obviously, in an ideal world, a collaborative team and develop an individualized treatment plan, and then promote a healthy weight. And all of these, I don't want to call them platitudes. These are all really true aspects of living with FCS. Make a list of favorite foods. There's sometimes, and then get to the root of what fuels your cravings, and then FCS friendly versions of foods. So there are strategies, and in fact, some lipid clinics actually do have this, and hopefully now with social networking and the internet, that in fact some of the tips and tricks that are used in clinics can become more widely known. So we want to like empower people to control and individualize their diet, and that would then at least help with long-term adherence. Does any of this ring true, or are there anything that this brings to mind, Jeff? This
Oh,
points on this slide.
definitely. And the sad thing is, on paper, it looks great. Saying it
Yeah,
sounds phenomenal. Executing long term is challenging.
yeah,
Uh, but there are more outlets. There are uh, more sites that you can go to, and different recipes. And I'm involved in a lot of different aspects and trying to just share information, which is
right,
why I think this is so great what we're all doing tonight.
for sure, absolutely. So these are then the lifestyle recommendations, very low fat. You can see the fat content there, either in terms of grams or percent fat. And then, some tips there in terms of then, we had talked about medium chain triglycerides, avoiding alcohol, avoid simple sugars just for the glycemic load, and then achieving adequate, intake of fluids, water, electrolyte balance, nutrient dense foods. You make sure that the essential fatty acids are met. So these are all, key dietary components, fat free or low fat foods. Whoops. And then I just wanted to, we have a question coming up. So now just going to go back to Richard. So Richard, as you can imagine, he's having issues. He's 19. Uh, Difficulty adhering to the diet. His triglycerides have come down, but they're still over 2,000. He's still at risk of pancreatitis. Pharmacotherapy in terms of our standard, fibrate, statin, niacin, because there is a lack of lipoprotein lipase or lipolytic capacity. These traditional therapies, you think, oh yeah, well just put them on a statin and a fibrate, that should clear it up. No, wrong. In FCS, like where there is the genetic issue, the genetic deficiency, these traditional drugs don't help it. In fact, the diet is the cornerstone of treatment. Let's go to the next question and answer section, and I'll read it. What is the major finding? There was a study a few years ago in the New England Journal on a new drug for high triglycerides for familial chylomicronemia, volanesorsen. Volanesorsen mediated clinical benefit in triglyceride reduction, was rapid and was maximal by the fourth week, but ceased by 8 months. Anemia was a common side effect or common cause for discontinuation, occurred in a third of the patients. There was ocular injury associated with volanesorsen, was limited to the first 3 months, no new cases. Volanesorsen induced a dose-dependent and prolonged reduction of plasma ApoC3 and concomitant lowering of plasma triglycerides, or if you're not sure, just click on you don't know. So we'll hear that lovely music again. Okay, so the correct answer was actually outlined in the box. So volanesorsen induced a drop in ApoC3. It's an ApoC3 inhibitor, and Dr. Whitstone will get to that mechanism in a minute. And it lowered triglyceride levels. So all the other answers, the ocular injury, anemia, clinical, like transient clinical benefit, those were all false. So what we had here with it, volanesorsen was a proof of concept that if you interfered or reduced ApoC3, that this would be associated with dramatic improvement in triglyceride levels. So at this point, I'm going to turn the session over to Dr. Whitstone in San Diego.
Thank you, Rob. Excuse me, I managed to get a cold with my grandson in the last few days. I wanted to use a series of cartoons to try to explain you a little bit about triglyceride metabolism and why the drugs that you usually use to lower triglycerides don't work, and why in the last 10 years we've developed a novel understanding of a new way to approach lowering triglycerides that's applicable to FCS, that is by interfering with the production of apolipoprotein C3. So in this little cartoon, if you imagine that Erlenmeyer flask is your plasma containing triglycerides, so there are two sources of input of triglycerides into the plasma. There's the liver on the left, which comes into the form of, makes triglycerides in the form of, imports them in form of VLDL, and then the intestines, which put chylomicrons into the bloodstream, and these consist of completely driven by dietary fat. And then there are outputs. By far, as Rob explained to you, lipoprotein lipase, shown on the left, is the dominant pathway that leads to hydrolysis of triglycerides and clearance, and is by far the most important. And then there's another pathway called the LPL independent pathway, which is made up of a number of less specific pathways, less high affinity, so to speak, but also involved in clearing triglycerides. Now, the important point to note is that if you, and the reason that chylomicron restricted fat diets work is when you restrict fat in the diet, you remove chylomicron input into plasma, and that's a major source of triglyceride input into the plasma. And to date, it's the only effective form of therapy. And as Rob explained, all of the other drugs we use for hypertriglyceridemia primarily depend on having LPL dependent clearance, and you need active lipoprotein lipase. So one of the things that the last 10 years of history and extensive research has taught us is that an apolipoprotein called ApoC3, which is made primarily in the liver, and it enters into the plasma on VLDL, or it comes from the gut in form of chylomicrons. It was noticed that the ApoC3 levels and triglyceride levels correlated very highly. And then it was shown in animal experiments that if you inhibited ApoC3, you lower triglycerides, and it was directly shown that the mechanism is that ApoC3 actually inhibits lipoprotein lipase activity. And so volanesorsen is an antisense drug that's oligonucleotides that are injected into the blood, and they go to the liver, and then they bind to the RNA that is responsible for ApoC3 production. And as a result, it causes degradation of the ApoC3 messenger RNA and therefore a decrease of ApoC3 production. And it was theorized, therefore, that if you inhibited ApoC3 and lowered plasma levels of ApoC3, you would in fact remove that inhibition on lipoprotein lipase, and therefore you would lower triglycerides. And this was shown in a study that was published over 10 years ago now. And it was shown that, in fact, in studies in rodents and non-human primates and humans, that the antisense-mediated inhibition of ApoC3 messenger RNA in the liver, in fact, lowered plasma triglycerides. And so this was a groundbreaking observation that for the first time provided a very novel way to lower triglycerides. Well, FCS, as we said, as Rob explained to you, is primarily due to inhibition of lipoprotein lipase activity. So in thinking about using volanesorsen and FCS, the paradigm was saying if you inhibit ApoC3, you might reason that it would be not helpful because, after all, I just said that ApoC3 inhibited lipoprotein lipase, but lipoprotein activity is absolutely absent in patients who have FCS. So why would you consider using volanesorsen to inhibit ApoC3 in these patients? Well, it turns out that in the literature, there was evidence that lipoprotein lipase was also independent clearance. That is, some of these other pathways shown on the right side of this cartoon might also be dependent on ApoC3. And actually, some of that data was 10 years old, but everybody had discounted that because it had been determined in mice. But the scientists at Ionis and the clinician thought if ever there was a way to test whether or not ApoC3 inhibition worked on the LPL independent pathway, it would be in patients who didn't have LPL to begin with, as you can see. And so what you can see is that a study was done, a pilot study in 3 patients who had genetically shown deletion of LPL activity, and remarkably, there was a very dramatic reduction in the triglyceride levels, proving that the LPL independent pathway was important too. And you can see that the study, which is published in the New England Journal, only had 3 patients and therefore represented novel biology. Well, this was repeated a number of years later using a larger number of FCS patients, 66. And again, it confirmed the results, showing that there was a 71% reduction in triglycerides, and these triglycerides were very high to begin with. So this really, for the first time, points out the potential therapy and a potential novel therapy for treating FCS patients and lowering triglycerides below a value that would result in pancreatitis. So can I go back? Yeah. So you can see that the lessons that we learned are that ApoC3 inhibits both LPL dependent clearance as well as LPL independent clearance, and therefore its central regulator of triglyceride levels, and inhibition of ApoC3 with a drug like volanesorsen should be applicable to lowering triglyceride of any etiology, but especially pertinent to our conference for patients with FCS. And I know some of these slides are advancing on their own. The volanesorsen was just to quickly point out that in an open label extension study in which there were patients both with FCS as well as multifactorial chylomicronemia syndrome, it was effective in lowering in a real life situation, not even in a clinical trial, but here you can see where patients were doing it and it was producing very dramatic reductions. Now, volanesorsen has actually been approved in Europe, but it was not approved in America because there were some side effects, such as thrombocytopenia, that made it less desirable. And so what's been done was to take this antisense and to put a molecule of galactosamine on it, attached to it. And the galactosamine actually binds to a receptor on the liver called the acylglycoprotein receptor, which is present in a high concentration. And it binds and internalizes the antisense, and then the ligand, the antisense is cleaved off, and then it can go into the liver cells and go into the nucleus, where it can inhibit the production of the ApoC3 protein. And the importance is, because it's targeted directly to the liver, much lower doses can be used. And now it's been widely confirmed that when doing this, the much lower doses that still achieve the ApoC3 lowering also reduce the side effects to a very tolerable level. And this is just this new drug, which is called olezarsen. You can see it causes a dose-dependent decrease in patients with hypertriglyceridemia. And the good news is that it has just been tested in a phase 3 trial of patients with FCS. And although all the results are not yet in, it was reported at the American Heart Association that the very important benefit of lowering triglycerides is that it actually reduced the number of new cases of acute pancreatitis. So there is a new effective therapy available for FCS that hopefully, after it goes through the new regulatory findings in a short period of time, will be available to reduce triglycerides sufficiently to prevent pancreatitis in patients with FCS. Finally, just to be the fact that ApoC3 is so effective and when you inhibit it in lowering triglycerides has led other industry pharmaceutical companies to develop their own antisense. And in fact, other approaches of other proteins that are known to affect triglycerides are also being attacked. So in the near future, it's very likely that we'll have a number of therapies that will be highly effective in lowering triglycerides. So I hope that makes it clear to you why the ApoC3 at least has been a very valuable target, and that effective therapies are around the corner. And with that, I'll turn it back to Rob.
Great. Well, thank you very, very much, Dr. Whitston. So, yeah, these anti-ApoC3 drugs are like a true breakthrough in the management of these patients, which in fact was, in many, was often like, I wouldn't, not quite to far say a lost cause, but certainly amongst the most challenging in lipidology to treat. So it is fantastic that we now have these therapies on the brink that provide hope. So just to summarize what we've discussed this evening so far, diet and lifestyle at the moment are the cornerstone, the mainstay of FCS management. It is important for to be definitive to confirm a genetic cause if it's accessible. I mean, that's the issue, is the accessibility of the genetic testing. You can use a clinical suspicion or clinical scoring of FCS, but in fact, we're living in 2023. It's the genomic era, and these are genomic treatments. So it's good to confirm the cause genetically. Current therapy options are not sufficient, but fortunately, on the horizon, we now have these very promising antisense treatments based, directed to RNA. And these do appear to safely give prolonged and effective reductions in triglyceride levels. So just to finish on the story of our patient, so he was able to receive through a special access program, volanesorsen, at that dose for that drug, 300 milligrams biweekly subcutaneous. And here you can see that the triglyceride levels then came down. So really, if you think he started at 6,000 and then with lifestyle was around 2,500, so there was a further 50 to 60% reduction cholesterol is never an issue, as it is typically not with these patients, but definitely was in a much better place with his triglycerides. Some challenging clinical challenges, fatigue, GI disturbances, social issues. So the SMART goals, we are specific, measurable, attainable, relevant, timely, see patients with severe hypertriglyceridemia, receive genetic screening if accessible, support patients with FCS by providing resources to connect with other patients, engage the full multidisciplinary team in the management, and educate patients on the topic of ongoing therapies and ability to participate in clinical trials. I think we're now in the question and answer session. We do have a few minutes for questions, and I'm seeing that we have some coming in, so I'm going to open that up, and I'll ask my colleagues to be on standby. So the first question, is a clinical diagnosis of FCS sufficient, or do you need the genetic test to treat? So what do you think, Alan?
Obviously, if the genetic test is available, it's very useful. But as you've already alluded to, it oftentimes isn't. And therefore, if you can make a diagnosis on clinical grounds, you've got the current type of tool that I mentioned to you, and there are new tools being developed, as you know, Rob, specifically for North American populations. So I think if the patient fits the criteria clinically, you don't have to have the genetic testing.
And then, yeah, I totally agree. We have a new scoring system for North America that should be published hopefully next year. Does a negative panel? So if the genetic testing is negative, but the clinical score is positive, does that still mean FCS? So I would say yes. I mean, a lot of it then depends on the issues of what a third party payer then would consider. But you can certainly say there would be a term of indeterminate genetic testing, but clinically consistent with FCS. So I would say there's the wording that would fit that. Another question: will the antisense drugs benefit patients with non-FCS, and should we suggest? So, Joe, what do you think with the non-FCS, so the multifactorial chylomicronemia? Do you think we would get just as much benefit with the targeting ApoC3?
Yes, as I indicated, the methods, because in the method slide, it inhibits both the LPL dependent and the LPL independent, and since most multifactorial patients will have some degree of LPL activity, you will get benefit from that side as well as the LPL independent. And all the preliminary data from Ionis as well as some of the other companies now making them is highly effective in all severe hypertriglyceridemic patients.
Yeah, for sure. Question about gene editing. So I'm aware that Verve, which reported the amazing results in the 10 patients that I'm sure you saw like on Monday, made the media in familial hypercholesterolemia. So I'm aware that they actually have a program as well in ANGPTL3. And I think there is also an interest in several of these gene editing companies on ApoC3 as a target. But it's very, very, very early days for that. Question for Jeff. Are you currently taking, in addition to your diet, are you taking any medications for your triglycerides?
I am. I am taking the fenofibrate and Vascepa along with a small statin. Nothing's giving any adverse effects, so my doctor feels if it's not hurting, at least hopefully can help a little bit.
So thank you for that. And then along those lines, so what do you think? So the Vascepa, the marine fatty acids, omega-3, Alan, what do you think about FCS patients receiving those? What's the current thinking?
Yeah, I don't think they should receive them. I mean, marine fatty acids are fatty acids. They're absorbed in chylomicrons. They form chylomicrons. It just doesn't make sense for them to get it. However, one's got to consider the possibility of essential fatty acid deficiency. So one needs to get a small amount of essential fatty acids from polyunsaturated fatty acids, but I wouldn't recommend marine oils as a therapy to bring triglycerides down in FCS because they don't work.
Yeah. And anyway, final question about the approval status of elanesorsen not approved by FDA. Olezarsen will be considered by the FDA. So we're sorry we didn't get to every single question, but we got to most of them. So I'd like to that's all we have the time for today. Let me just go back to the presentation, and just to thank my colleagues, and to after the show, sorry, there you can visit the Rare Disease Hub, and there are free resources and activities. So there's the website there for you to visit, and to receive the CME credits for this, you have to complete the post-test and evaluation online and click on the request credit tab to complete the process and to get your certificate. And I would like to sincerely thank everybody. So to thank Dr. Chait, Dr. Whitston, Jeff Wertalik, our patient representative, and to thank the people that organized this and the sponsor, and to thank all of you for attending. And hopefully you have enjoyed it as much as we have. So thanks very much, everybody.